Welcome to our special panel, The Role of Family Caregivers in the Healthcare System, sponsored by AARP and WTOP.com. I'm WTOP Capitol Hill correspondent Mitchell Miller, and joining us on our panel are John Poole, virtually, a former family caregiver and caregiver advocate, Dr. Mina Seshamani, Director of the Center for Medicare at the Centers for Medicare and Medicaid Services, Dr. Benjamin Powers, a surgical oncologist at University of Maryland Capital Region Health, and Nancy Lamond, the Chief Advocacy and Engagement Officer for AARP. Welcome, everybody. Thank you very much for joining us. All right, Nancy, I'd like to start with you. Caregiving, of course, is a major issue for so many families, and it continues to grow with the aging population. Can you start us off by talking about just how big of an issue this has become?
Well, sure, and thank you very much for convening us today. There are 48 million family caregivers in the United States, and put that in perspective, it's roughly 10 times more than paid caregivers. And as a group, it is the most diverse workforce in healthcare. If you think of it, for this unpaid job, this doesn't discriminate on the basis of race, gender, or age. 60% of all of those caregivers are women, 40% are people of color, 30% are millennials and Gen Z, 7% are over the age of 70, and fully 30% are managing both care for their parents and care for their children. So not only is it a big group, but it's also a very diverse group. And we know that family caregivers are doing all kinds of things for their loved ones. They're taking them to appointments, shopping for them, handling some of their financial matters. But increasingly, as more care is being delivered in the home, they're doing more complicated medical tasks, handling wounds, prescriptions, thinking about how to manage all those machines. And so it's increasingly important, and I'm so pleased we're going to talk about it today, increasingly important that we see this group as a key part of the medical care delivery system.
Right, and these people, they are uncompensated. This costs, it's estimated in the hundreds of billions of dollars, how much they provide in connection with the U.S. economy. I wonder if you could talk about some of those challenges as we get into this conversation.
Sure. Well, roughly 61% of all family caregivers are working full or part-time in a paid position. So this is on top of it. And the estimates are that this care accounts for roughly $600 billion to the economy. And that's more than all out-of-pocket spending on healthcare in the United States. So it is a huge economic issue. It's an economic issue for the healthcare system, and it's also an economic issue for individual families. We estimated in a study a few years ago that the average caregiver was spending around $7,000 of his or her own money in order to augment the care for a loved one.
And speaking of the medical system, Dr. Seshamani, obviously this has huge implications for Medicare and for the federal government. I wonder if you could talk about some of the ways that Medicare and maybe the federal government in general is trying to adjust to these major demographic changes.
Absolutely. And again, I'll echo the thanks of convening us for this very important topic. You know, before I took this role leading the Medicare program, I was a physician taking care of patients and saw firsthand how important it is that we care for people rather than just treating a disease. And I think the caregiving issue is front and center with that, where, you know, as a physician, you can see someone for 15 minutes. In your office visit, there's a whole lot more that goes into caring for someone, that goes into their health than just that 15-minute office visit. And we at Medicare are really looking to how we can make sure that the system is having that broader support. You know, so for example, we just finalized for the first time payments to healthcare providers so they can train caregivers. Because to the point that, Nancy, you were making, people are doing a lot more in the home, and what training do they have for things? And particularly as we know that behavioral health is so closely tied with physical health, making sure that people have the supports they need to be able to manage things, you know, in that broader perspective.
And our other doctor here on the panel, Dr. Powers, you deal with patients that have very serious health issues in many cases. I wonder if you could talk to us a little bit about some of these challenges that were just alluded to.
Yes, happy to discuss this. I think, again, I would like to also give thanks for my ability to participate here today and discuss this incredibly important topic. As you know, a diagnosis does not begin in really the hospital. These are symptoms and a variety of other issues that lead up to patients coming to a physician's office. And caregivers have an incredible role in not only navigating patients to get to see a healthcare provider, but then across the entire phase of diagnosis to staging in the cancer arena, then to treatment. These are all critical functions that caregivers help support and augment care for providers. And so certainly for my patients with complex gastrointestinal oncologic issues, the caregiver plays a critical role. And that could be everything from managing tubes and drains to assistance with ostomies, making sure that patients are able to get to appointments, completing paperwork for various medical supplies. The burden that we place on caregivers is tremendous, and this is just such a wonderful forum to be able to discuss these issues in the way that we can not only better assess the needs of caregivers, but try to lower barriers that they face when we're trying from a provider side and from a healthcare side to be able to really improve care coordination and other aspects that caregivers face.
And you mentioned paperwork. I have friends who are physicians, and they have told me many times that they love their work. This is why they got into it, is to help people, to make them healthier. But the paperwork obviously is a whole nother issue. And then when you compound it for a caregiver who is under some of the most stressful period of their time, dealing with cancer, that type of thing. I wonder if you could talk to us a little bit about efforts to try to, or your concerns about how that compounds the stress on a caregiver. Either of you could talk to me about that.
If you want to start, and then I can chime in.
Sure. A lot of the research that I have done has been in the space of health insurance literacy and care coordination. One of the studies that we did at my prior cancer center looked at health insurance literacy not only for patients, but also for caregivers. We found that roughly 30% of patients met criteria for being health insurance literate, and about 50% of caregivers, which perhaps isn't surprising and reflects the amount of work that caregivers are actually doing in terms of navigating independently the health insurance system for patients. And so I think, again, that amount of paperwork that they're doing is incredibly important. But it's not only that, it's interfacing with the myriad number of providers that, particularly in my area, cancer, that patients interact with. This can be everything from nutritionists and making sure that they fill out paperwork to be able to get boost or insure for nutrition, to, again, ostomy supplies or other, wound care supplies that are needed, and then obviously health insurance, dealing with all of the issues in terms of the cost of care, and then, parking. It's an enormous amount of paperwork that caregivers provide. And I think, some of the things that perhaps we can get into a little bit later would be the interventions that we've helped sculpt to be able to, again, lessen those barriers and make things easier.
And I know there have been efforts to try to start streamlining a lot of these processes.
Yeah, that's right. I mean, I would say the burden that we're talking about with caregivers into kind of three buckets. The first being, that interface with the insurance companies. And we have, as Nancy is chuckling, we recently put in place regulations on what's called prior authorization, where in Medicare Advantage, where a private plan is providing Medicare to people, they can say, well, we need more information to determine whether we're going to, cover that care. And we put in place requirements that Medicare Advantage plans have to follow the coverage decisions of traditional Medicare. If there's a national or local coverage decision of traditional Medicare, Medicare Advantage cannot impose additional burdens on top of that. That is a burden for not just the caregiver, but also for the healthcare provider taking care of that person, the amount of confusion that it creates. We are now taking that one step further in the regulation that we just released, where we are proposing that plans have to do an analysis of the disparities that may or may not exist in this prior authorization. And I see you're smiling. It comes back to what Nancy said, that caregivers are 40% people of color. And I think we all know that the people, when systems are complex, the people who fall through the cracks are not the people who are well-versed in the healthcare system. It's people who have low English, English proficiency, people who don't have family members, who can help them out. And so being able to incorporate that equity consideration in this burden is also important. And I think a second point that has been talked about a little bit is the myriad of marketing that occurs, where many people, especially right now, we're in Medicare open enrollment, where people are supposed to be looking for the best option for them. The number of people who are helping their loved ones to make the best choice and getting bombarded by television ads and, saying, you're going to get a free card here. And we have put in place regulations to limit misleading marketing practices as well, which again is something that's like a buffeting on caregivers. And the third is that navigation that Ben mentioned, where we actually, alongside paying for caregiver training, we are now going to be paying for care navigation services for social workers and others. And that again is a support for the caregiver, right? Particularly for those with serious chronic illness, that we can pay for the system to provide care navigation so that it's not all on the backs of, the unpaid caregivers.
That's a really great point. I mean, I think of myself as a relatively intelligent person, but going into some of the paperwork that I've seen on healthcare matters, it boggles the mind how much we have to deal with. One of the people, of course, who is dealing with this on the front lines is John Poole, and we're going to get into more details with you, but I wonder if you could just talk a little bit, John, initially about some of the challenges you have dealt with.
Well, I was caregiver for my parents simultaneously after they suffered strokes within a month of each other, and it was a very intense situation, as I'm sure all of you can imagine. Well, let me also thank all of you for sharing your thoughts and inviting my participation to this panel discussion. I really do appreciate it. So, part of what I found most challenging when I was managing my parents' care is that there was very little clear communication with healthcare and insurance representatives. So when the rest of the panelists were speaking about trouble with insurance issues and understanding the process of navigating the whole field, that was very relevant to my experience, because there were times that the information I was given by insurance officials where it was not correct and ended up costing my parents money out of pocket, which should have been covered by their health insurance policies. They have Medicare and a supplemental policy, which I was not given the correct information on some things, which ended up costing them money out of pocket, which they then need to pay. One example of this is that my mother had a PEG tube, a percutaneous endoscopic gastrostomy tube, after a stroke because she lost her ability to swallow, and the tube was meant to provide her with nutrition and medication, which I was charged with administering the tube-related tests. So, because she was paralyzed, she relied on stretcher transport to get to and from her appointments to get the tube replaced every few months. I was told by multiple people at Medicare and their supplemental insurance that Medicare did not cover stretcher transport under any circumstances. And stretcher transport can cost roughly $700 to $800. So each time they would just pay out of their own pockets, because I was told by officials that Medicare did not cover the costs. I later found out that PEG tube replacement was one of the instances where Medicare did pay for stretcher transport. However, that was after maybe $4,000 to $5,000 spent out of pocket of my parents' money, and I would have appreciated knowing that information before. So I think one of the main issues is communication for caregivers to have clear communication with the people who are sharing information with them, so they can better administer their loved one's care and manage their finances better.
Well, thank you, John. I'm sorry for everything that you've had to go through, and your story is not unique at all, as our panel knows. I'd like to get into some of the things that you would like to see happen. You just touched on that a little bit, and we'll get into that, as well as what Congress is doing, what things are being done from a policy standpoint as we move forward on this very important issue, and we'll talk about that in our next segment.